I'll start with the definitions of constipation, diarrhea, and rectal bleeds. So with constipations, generally we can say constipations are infrequent passing of stools. So they are in terms of frequency. So it is technically less than three bowel movements per week. However, constipation can also be sometimes patient might explain it as the feeling of hard stools and stools that are difficult to evacuate. And then there is a need for self-digitation to evacuate the stools. So constipation can also be further classified as acute and chronic constipation. Acute constipation is something that can begin suddenly and noticeably, but chronic constipation takes it's gradual. So maybe the patient might not even realize that, okay, and then it persists for many months or years.
Is there a duration that you would characterize this patient as chronic constipation? They give
Yeah,
timeline. Okay, you say okay, this patient has chronic constipation.
uh, 3 months, doctor, for it to be chronic
Okay, at least
constipation.
3 months, right? Mm. Okay.
So then we further classify into primary constipation where there is no identifiable cause,
Mhm.
and secondary constipation there will be identifiable cause. And I'll talk a little bit more about this later. Lah. So next we go to diarrhea. So diarrhea is the complaint of change in consistency of stools. So patients might describe it as loose or watery. So it's increase in volume where the stool weight is more than 200 grams per day. And sometimes you can also say it's an increase in frequency, so more than three a day, or a change from their previous frequency. So it's important for us to ask about frequency and volumes. But the main thing from what I've read is that with diarrhea, it's all about the consistency. So asking the patient whether the stools are loose, watery is very important. Okay. And I'll go into the types of diarrhea here. So just a brief overview since we've learned this before. So inflammatory diarrhea, it is due to the damage to the intestinal mucosa, as you know, that's lining our digestive tract. So when there is such damage, it actually induced cytokine-induced water hypersecretion. And with that happening, this hypersecretion is actually what causes that watery diarrhea that we are thinking of. But at the same time, because the barrier of our intestinal mucosa can easily be invaded by microbial, viral pathogens, and then it leads to the epithelium being disrupted. So serum and blood can also be released in the intestines, causing widespread destruction of the epithelium, and that actually can impair absorption of active substances because when there's going to be destruction, you are going to try to replace the cells with more immature cells that lack the same enzymes, lack the same maturity. So it can also cause an impact absorption of these active substances. So for malabsorption, so the term malabsorption refers to impaired nutrient absorption at any point where the nutrients are absorbed. So they can come from defects in the digestion or the absorption process. So example, certain diseases can cause you to have acquired damage, sorry, not damage, but damage of the mucosa, or even inherited disease of the mucosa, or sometimes damage to the intestinal membrane transport systems. For watery diarrhea, that can be subdivided into secretory watery diarrhea, osmotic diarrhea as well. So with secretory, it's more active secretion of water into the intestinal lumen, and with osmotic, it's like poor absorption or sometimes excessive ingestion of hydrophilic substances. For example, if ever seen means like patients who consume a lot of laxatives for weight loss as a weight loss.
So how do you classify those diarrhea? You should this is like bit haphazard. So there must be either you classify them by cause, right?
Yeah.
By but this is this cause inflammatory, infective. What other causes of diarrhea that you know of?
Uh,
Could
okay.
you say?
Yeah. So actually, I should have explained a bit
Mhm.
more. So this should be causative. So like inflammatory diarrhea, I should also write infectious diarrhea,
Mhm.
malabsorption, got maladigestion diarrhea,
Mm.
and like fatty diarrhea actually, which is what malabsorption and maldigestion diarrhea is. So yeah.
Okay. All right.
So we'll move on to the next one, parectal bleeds. So parectal bleeds, so basically it is bleeding through the anus, but we can actually subdivide it into like outlet bleeds. And in outlet bleeds, they are seen as bright red, seen only on toilet paper, meaning when the patient tries to wipe, then you could see it on the toilet paper. Or in water, so water in the toilet bowl itself. Lah. Some suspicious bleeds like dark blood, blood associated with mucus, or blood or on or in the stool. And sometimes a hemorrhage, so an acute large loss of blood volume. So the picture down here actually shows you the differences. Like example, when someone has melena, which most commonly is an upper GI bleed. However, sometimes they can be part of the lower GI bleed as well. Example in cecal bleeding, and then hematochezia, as you can see, is a bit more of a fresh blood as compared to the black tarry stools that we see in melena. Okay. Okay, so now I'll move on to the causes of constipation,
Okay,
diarrhea,
can
and
you go back to
oh,
that slide?
this one, doctor.
What do you mean by outlet bleeding, suspicious bleeding, and hemorrhage? What is hemorrhage?
Uh,
Hemorrhage is also bleeding, right?
yeah, yeah. It's more like, from what I've seen, it's more like an acute, like in this case, like large volumes of blood loss. But with outlet bleeds, they can be like bright red, just seen like this, and then they're usually with no prior history of
So
like,
so how will you divide them? Upper GI bleeding or lower GI bleeding? That would be more this one, right?
yeah, okay, yeah,
Right. Okay.
yeah.
So if lower GI bleed, where is your cut-off point?
Lower GI bleed, so we use the ligament of Treitz to,
Yes. Okay. Below that. So this classification, I mean, this how the way you divide it sounds. I mean, it didn't seem like.
doesn't seem so, yeah.
Yeah, it's like it's just a description of the blood.
Yeah.
Okay, from your GI tract. So shouldn't be like that lah, right? Okay, you should divide properly upper GI bleed or lower GI bleed. Obviously, if let's say you want to say whether is it like bright red, dark red, okay, whether is it melanin stool or whatsoever, right? It could give you an idea whether is it from upper GI or lower GI. But if you get fresh blood, that also doesn't mean that you um, that doesn't mean that it's not upper GI bleed as well.
Yeah.
Okay, so you must always remember if let's say fresh blood, sometimes it can be massive upper GI bleed where patient very quickly pass out fresh blood as well. So how would you during your assessment, right? How would you gauge if this patient has an massive upper GI bleed, or the hematochezia that you see is due to lower GI bleed?
Um, so we should ask further on like the associated symptoms. So if it's like a massive bleed, we should also ask in case of shock symptoms.
Mm-hmm.
We can ask for example postural hypertension. Sometimes if the patient experience palpitations.
Well, if let's say chronic bleed, also they will get this kind of anemic symptoms, right?
Yeah.
Mm-hmm. So how would you differentiate them if this is a likely upper GI or lower GI bleed in
Then it
patient?
would be usually if it's an upper GI bleed, by the time it comes as a proactive bleed, it's usually darker in color as compared
Not
to
necessarily. Mm.
um they present as melena, doctor, so blood mixed in the stools as compared to
Melina. Yeah. I mean, no. I mean, how you differentiate whether is it melinic stool or fresh PR bleed? Okay. What you said, yes, melinic stool, upper GI bleed, but can upper GI bleed present with hematochezia as well?
oh no, they don't present with hematochezia, more hematemesis. So
You sure? What is
so sure, doctor.
okay? So you must always remember, right? When you assess patient with PR bleed, first of all, you must assess hemodynamically. Okay, if this patient is stable or not. If the patient came with hematochezia like that, okay, you must see if let's say patient is stable or not. Okay, so if they say patient is unstable, present with hematochezia like that, right? Okay,
Hmm?
it is possible that you should think of massive upper GI bleed, meaning that the bleeding on the upper tract is quite severe. Okay,
Okay.
most of the time lower GI bleed, yeah, most of the time they are stable, right? Sometimes maybe they might present to you with anemic symptoms because the duration of the PR bleed is quite some time already before they present to you. Okay, so this one probably give you some thoughts lah. All right, so that's why your classification for your hemorrhage, okay, right? That one you must know. Okay,
Okay.
what's the grade of bleeding?
Hmm. Okay, doctor.
Mm.
Okay, thank you. Okay, so now I'll go into the causes of constipation, diarrhea, and rectal bleeds. Okay, so these constipation causes are divided based on system. So, example, gastrointestinal causes of constipation include mechanical bowel obstruction, as seen when someone has volvulus, obstructed hernias, diverticulitis, colorectal carcinomas, colonic or rectal strictures. So, we'll get to see more about the associated symptoms and PE a little bit later. So, besides that, there's also ileus. Example, when someone has a post-operation, it can cause post-operative ileus. Same thing. And irritable bowel syndrome. So in irritable bowel syndrome, there's actually various subtypes. So there's constipation predominant, diarrhea predominant, and mixed. So this case, I'm talking about the constipation predominant irritable bowel syndrome, which primarily represent with constipation. So for neurological causes, there's also a lot. Some of the very important causes are some common causes are like Hirschsprung's disease, Chagas disease, Parkinson's, stroke, neuropathy, and spinal cord injury. Okay, like just a little bit about Hirschsprung's because I also didn't really know about this, but Hirschsprung's is actually more of a congenital aganglionic megacolon. So patients are actually born without with an aganglionic recto sigmoid a sigmoid colon. So they actually can cause
Ganglionic
the
segment. Okay, anywhere
aganglionic
along,
effect.
yes.
Yeah. So therefore they're unable to relax. So it causes a functional issue. That's why constipation. Okay, so metabolic causes, hypothyroidism, as we know, hyperparathyroidism, hypokalemia, hypercalcemia, and patients who do have diabetes mellitus, as we've seen a lot of them in our IM posting. So constipation, some medications can also induce constipation, but not if they take it like once, lah. Like usually it's some level to it. So number one is an analgesic. So sometimes patients take a lot of NSAIDs. Antihypertensive. So some from what I've found, a lot of beta blockers as well can cause constipation. Bile acid resins, or we know them as bile acid sequestrants. So usually treated to lower down patients' levels of lipid. Example here is actually lower down the LDL. Neurotransmitter altering medications like antipsychotics, anti-Parkinsonian medication, and antidepressants.
Okay, maybe the cost of drugs. Okay, you have to look for the most common the most common drugs that could cause constipation. Okay, analgesia, antihypertensive, like beta blocker, what you mentioned, those are very rare, probably like how many percent only, maybe less than 1%, right? So, so I mean, how many patients that you've been prescribing these patients on painkiller and patient who have heart problem or hypertension, beta blocker gets constipation.
Yeah, that's
You see,
often nice.
almost, almost,
Yeah.
almost very rare, right?
Mhm.
So when you do your presentation, you have to look for, if let's say you want to talk about drugs causing constipation, you should look for the most common one. All right, at least knowing that these drugs are that could cause constipation. Okay, maybe antipsychotic, anti-Parkinsonism, these drugs possibly causing, and also which one? NSAIDs, no, not NSAIDs. What kind of energy said that could cause constipation as well?
Uh,
More common one rather than NSAID.
op- Sorry, opioids, doctor.
Opioids, right?
Yeah.
NSAIDs, never lah. And what are the mechanism that actually could cause constipation for NSAIDs?
If I'm not mistaken, it has to do with the. Wait, doctor, I think I shouldn't answer. I should properly search.
Okay, all right, never mind. Just go back and look for it. Okay, all right.
Okay, so I'll move on to the diarrhea. So this is based on the earlier division. So with inflammatory diarrhea, some examples: ulcerative colitis, Crohn's disease, colorectal cancer, and infections as well. So these are the list of infections. These are just not limited to these ones. So there's a lot. So I can read also. I'll just move to the next one. Malabsorptive diarrhea includes example with infections like tropical sprue, Whipple's disease, and sometimes history of ileal resection. This means like maybe they had a prior surgery done and then they remove some part of the ileum. So this is basically reduces the surface or the time it contacts for with the ileum, the epithelium for proper enzymatic digestion and so on. So and enzymatic digestion. That's why you can get diarrhea as well. And then exocrine pancreatic insufficiency is actually more so with the maldigestion, actually not malabsorptive. Okay, so this was the watery diarrhea. So as you can see, divided secretory, osmotic, and some functional diarrhea as well. So with secretory diarrhea, as I already mentioned earlier, some endocrine disorders. So instead of hypothyroidism, you have hyperthyroidism, Addison's, diabetes mellitus, some foodborne infections. You can read it. Osmotic diarrhea, like osmotic laxatives. Sometimes patients concerned of magnesium citrate, carbohydrate malabsorptive. As example, when someone is lactose intolerance, usually this is what they'll present with. But this also can be considered a fatty diarrhea. So under the malabsorption, maldigestion, sorry. So functional diarrhea, diarrhea which is a diarrhea predominant IBS. So like I mentioned earlier, the subtype. So this would be the diarrhea predominant IBS. Okay. Okay. So this is the per-rectal bleeds. Okay, so I'm just going to go into the causes. So they're actually, these are not limited to these. There's a lot more. Example we have here is hemorrhoids that we've seen, anal fissures, anal abscesses or fistulas, diverticulitis patients as well, inflammatory bowel disease, namely with ulcerative colitis, colorectal polyps, and also angioectasias. So this is actually picture to show some of the hemorrhoids. This is the here up here is the angioectasia, the fissure, and these are polyps, but the polyps right now are not bleeding, but some of the polyps can bleed lah. Okay, so that is all for the causes and definition. I'll pass him to the next presenter to talk more about the history. Where to turn on the where's the thing? Oh. Oh, sorry, doctor. So we are actually all in the hospital right now. So I'm just
Okay.
gonna use. We're all using the same computer.
Okay, no problem.
So, good morning, doctor. My name is Fang Yi. So, I'll be talking about the history taking and physical examination part for our presentation.
Okay.
So, for everything, we have to start with introducing ourselves, confirming the patient's details such as name and the age, and then explain the purpose of the interview, and then obtain the consent from the patient before we start doing anything. Okay, so I'll be talking about the history of presenting illness first for diarrhea, constipation, and per-rectal bleeding. And I'm just going to emphasize some of the important points that we have to take note of during history taking. So for diarrhea, first we must clarify what patients mean by diarrhea. So as Tisha has mentioned, the definition of diarrhea, we have to listen to what patients complain about because sometimes the patients might have like a different perspective of what diarrhea is. And then we have to ask about the onset. Is it acute or chronic? Sorry, doctor, wait. Okay, sorry, doctor. Okay, I'll continue now. So for the acute onset, it can indicate some infections going on, such as gastroenteritis, or it can be colorectal cancer because a sudden change in the bowel habits can signify colorectal cancer also. And another one, and if it's a chronic onset, which is more than 4 weeks, it can indicate IBS, IBD, colorectal cancer, and also pancreatic insufficiency. After that, we must ask for the characteristic of the diarrhea. So we have to ask for the frequency, the volume, the color, and then the consistency, if it's watery, unformed, or semi-solid. And then also we can ask if the stool is mixed with blood and mucus, because this can indicate IBD. And also we can ask if the stool is floating, greasy, or pale with a very foul smell. This is called a steatorrhea, which will happen in pancreatic insufficiency. And then we can also ask if the patient is on any medication because some of the medications, such as laxative, can cause diarrhea. So some of the associated symptoms that we have to ask in relating to diarrhea can be abdominal pain, bloating, and dyspepsia. If the patient have all these three, it can indicate that the patient might have IBD. And if the patient have fever, nausea, and vomiting, then it can be an infection going on. And we also must remember to ask for the malignancy symptoms such as loss of weight and loss of appetite. And also we have to ask for some extra gastrointestinal symptoms such as eye problems and skin rashes because this can be a manifestation of IBD. And then we can also ask for tenesmus, which is this incomplete feeling of after defecation. and this is a sign of colorectal cancer. And also we can assess for some symptoms of hypothyroidism because as Tisha has mentioned already, that hypothyroidism can also cause diarrhea. So some of the symptoms includes heat intolerance, sweating, tremor, and palpitation. So now I'll be talking about the HOPI in constipation. So we can clarify first also what patient means by constipation and then ask about the onset. Some chronic constipation is caused by hypothyroidism and IBS, or is there any recent changes? Because like I've said, a recent change in the bowel habit, either constipation or diarrhea can indicate colorectal cancer. And then we also can ask for the stool frequency, the shape of the stool, and if the patient is on any medications such as the antidepressant, antiparkinsonian, and antipsychotic, and the opioid that Tisha has mentioned just now. So these are some associated symptoms that we can ask with in patient that is presented with constipation. We can ask for any bloating or cramping because this can indicate IBS, and then we also can ask for any hematochezia, which is a sign of colorectal cancer or diverticulitis or IBD. We also can ask for any weight loss because this happens in colorectal cancer, and then we can also ask for tenesmus also. And we can also ask if the patient can pass gas or not, any abdominal pain, vomiting, abdominal distension, any overflowing diarrhea. So overflowing diarrhea is when it is a very severe constipation, and then there will be a soiling of loose stool on the clothing, and this indicates fecal impaction. And then we can also assess some symptoms of hypothyroidism, such as cold intolerance and weight gain, and also assess some symptoms of hypercalcemia, such as bone pain, muscle weakness, and lethargy. So I would like to mention one point here. In absolute constipation, when there is no flatus and bowel movement, and when your patient have absolute constipation associated with pain, vomiting, and distension, it signifies an intestinal obstruction going on. So in the history taking for constipation and diarrhea, it is very important to ask the patient to describe the characteristics of their stools, right? And sometimes it is very hard for the patient to actually tell you how their stool looks like. So we can always use this Bristol stool chart to help the patient in telling you and giving you a clearer idea of how the shape and the types of stools. Okay, so the next one is the per-rectal bleeding. So in per-rectal bleeding, we need to confirm the patient's age because it can give you some idea of what might be the cause. So in younger patient, it is mostly the benign perianal causes such as hemorrhoids, anal fissure, or IBD. In older patients, it can be diverticular disease, colorectal malignancy, and also ischemic colitis. And then after that, you can ask the patient if this is the first episode or recurrent episodes of PR bleeding. If it's a recurrent episode, is it come and go or is it persistent? If it's a come and go thing, it can indicate a benign causes such as hemorrhoidal bleeds or anal fissure. And if it's persistent, then it signifies malignancy. The other questions that we can ask is how did the patient notice the PR bleeding? Is it on wiping? Because if it's on wiping, it can associate with, if it's on wiping and associated with pain, it can indicate anal fissure. And then also, if we ask the patient if the patient noticed the PR bleeding because of like got blood dripping into the toilet bowl, if it's like that kind of situation, it can indicate a hemorrhoidal bleeding. And then we also can ask if the blood is coating the stool or not. If it's a blood coating the stool, that is a distal bleed. If it's mixed in the stool, that is a proximal bleed. And then after that, we need to clarify with the patient like what is the color of the PR bleeding. If it's a frank red bleeding, it is suggestive of blood coming from the left colon. If it's a maroon color bleeding, which is like a darker shade of red, then it can be suggestive of blood coming from the right colon. And if it's black color, then it can be melena. Then after that, we can ask the patient how many episodes of PR bleeding already, and is there any presence of clot? This is to assess the severity of the PR bleeding. And then we also can ask for some associated symptoms, such as pain on defecation, bloody diarrhea with mucus, abdominal pain, and some symptoms of anemia, such as shortness of breath on exertion, postural dizziness, chest pain, and palpitations. And when we are doing all this history taking, we need to be aware of some of the signs of malignancy in PR bleeding. For example, recent change in bowel habits, a spurious diarrhea, which is like overflow diarrhea basically, uh, cancer thin stools, tenesmus, and some of the constitutional symptoms such as loss of weight and appetite. So for the further history, we can ask for any past medical history, any previous similar episode, history of GI diseases, bleeding tendency, history of hyper or hypothyroidism. And for the past drug history, we can ask for any antibiotics because some antibiotics can cause diarrhea, laxative, NSAIDs, antihypertensive, neurotransmitter altering medications such as the anti-Parkinsonian medication. And also we can ask for any past surgical history, some recent bowel trauma such as colonoscopy and bowel surgery can causes constipation. And in the family history, we can ask for any similar symptoms, any history of GI diseases such as IBD, any bleeding disorders, and also any history of malignancy such as colorectal cancer. And in the social history, we can ask for the dietary history also. Low fibers diet sometimes can cause chronic constipation, and and also we can ask for any food intolerances because like in patients with IBS, they have very specific food intolerances such as wheat or dairy products. You can also ask for some alcohol intake, the smoking, which is a risk factor for CRC and Crohn's disease, and any stress recently in life because IBS are exacerbated by stress and also some foreign travel, which is relevant in taking history for diarrhea. Okay, now I have reached the physical examination part. So we will start with taking the vital signs of the patient, such as the blood pressure, the pulse rate, the respiratory rate, the temperature, and the oxygen saturation. This is to assess if the patient is hemodynamically stable or not. And then after that, we go for the general inspection. We look at the patient in whole. If we see if the patient is in pain or not, is the patient pale, which is a sign of anemia. Look at the body habitus of the patient. Does the patient have any normal body habitus? Is the patient cachetic or obese? Look at signs of jaundice and some signs of hypothyroidism or hyperthyroidism in general inspection. Then we'll move on to the peripheral examination. In the hand, we can look for some nil-bake pallor, clubbing, colonychia, leukonychia, and also the capillary refill time. And for the face and neck examination, we look for some conjunctiva pallor, sclera jaundice, conjunctivitis, because extra gastrointestinal manifestation can be a sign of IBD, and then also angular stomatitis, atrophic glossitis, Ehlers ulcer, lymphadenopathy, especially Virchow's node, which is located at the left supraclavicular area. This is a sign of GI malignancy, and also enlarged thyroid. We can also look for some skin changes commonly found on the lower limbs, such as erythema nodosum and pyoderma gangrenosum. This is a manifestation of IBD also. So for the abdominal examination, we start from inspection first. Look for any scars, swelling, any asymmetry of the abdomen from the end of the bed, any visible peristalsis, which indicate intestinal obstruction. And then we will move on to the palpation. We palpate for any tenderness. If there's present or tenderness on the left in the left iliac fossa, then it can indicate diverticulitis. And if it's on the right iliac fossa, it can be Crohn's ileitis. And then we check if there's any palpable mass. If it's at the epigastric region, it can be a pancreatic cancer. If it's at the right iliac fossa, it can be a cecal cancer or Crohn's disease. If it's on the left iliac fossa, it can be a sigmoid colon cancer or a diverticular mass. And we also can check for organomegaly, which can happen in metastatic colorectal cancer. And then after that, we'll move on to percussion. Positive shifting downers can indicate a malignant ascites. And then we auscultate for the bowel sound. If the bowel sounds are absent, then it can be a paralytic ileus. If there's increased frequency, volume, and a high-pitched tinkling quality, it is a sign of intestinal obstruction. And then lastly is the digital rectal examination, where we put our finger into the patient's anal canal. So before we insert our finger, we have to inspect the perianal skin. Look for any skin lesions, external hemorrhoids, fissures, and fistula. And then after that, we insert our finger. From there, you can actually already assess the sphincter contraction, look for any weakness or not, because if there is weakness, it can be autonomic neuropathy, which happens in diabetic patient. And then you turn your finger around and then you look for any abnormalities of the mucosa. If there is abnormalities in the mucosa, it can signify a colorectal cancer. And also check for masses during the palpation around the rectum. And then you take out your finger and then you examine the appearance of the stool. So the abnormal appearance of the stool I've listed in this table. I'll just mention some things. If it's a fresh blood, then it can be a large bowel, rectal, or anal bleeding. If it's a stool mixed with pus, it can be an infective colitis or IBD. And if it's pale and greasy, then it can be a steatorrhea. And if it's black and tarry, it's a melena. Okay, so because our topic is on diarrhea, constipation, and rectal bleeding, and there are some neurological causes of diarrhea and constipation. So we can also add in a neurological examination in situation for Parkinsonism. We can assess if there's any tremor, rigidity, akinesia, and postural instability. And then also, for example, in diabetic neuropathy, we can also see if there's any loss of sensation in the glove and stocking distribution, and also hyporeflexia. So that's the last of my slide, and then I'll pass it to Ayman for the investigation.
Okay, during your rectal digirectal examination, also you have to examine as a whole, right? Okay, just
Yeah.
because your topic is a GI topic, all right,
Mm-hmm.
you also have to examine prostate as well, lah. All right.
Yeah.
Since you already put in the finger, you assess anteriorly, laterally, posteriorly, and circumferentially, lah. Okay. All right.
Okay.
So and when learn how to describe the mass that you palpated. Okay.
Okay. Okay.
Um, okay. Next. Any question you want to ask up to here? Boleh.
Truly sorry for the delay. So good morning, everyone. My name is Aiman Dino bin Hanisam, and I will cover the topic of investigations in our tutorial today. All right. So I divided my investigations into blood tests and others, and also some imaging tests that we can do. So initially, we can do a full blood count. So we can look for any evidence of anemia or leukocytosis. So for instance, in the case of constipation, when there is a colonic mass, the mass may bleed and causing anemia. So other than that, in diarrhea, uh, in disease like inflammatory bowel disease, it can also cause anemia from malabsorption of iron, folate, vitamin B12, or it can be just due to the blood loss from the disease itself. Or in the PR bleed, it may cause anemia because of the blood loss. So moving on to renal profile, we can do that to look for any electrolyte imbalance and also measure the patient's hydrational status. So in electrolyte imbalance, in constipation, hypokalemia and hypocalcemia may cause constipation. And in diarrhea, the patient may be dehydrated, and also they may have hyponatremia due to losing excessive fluid from defecating. And also in PR bleed, there will be raise in urea. So then we can also do thyroid function test to look for any evidence of thyroid disorders, just as what as presented by Tisha. Hyperthyroid or hypothyroid may cause problems in defecating. So in hyperthyroid, the patient may have diarrhea, or in hypothyroid, the patient may have constipation. Next, we can also look at the inflammatory marker like the ESR or CRP, because this just will indicate if there is any ongoing inflammation like inflammatory bowel disease or any inflammation. We can also measure the serum albumin to assess the nutritional status because in patient with chronic diarrhea or with malabsorption, the serum albumin will be reduced. Then we can also do random blood glucose because some of the causes of constipation and diarrhea is diabetes mellitus. So we can assess their diabetic control by doing a random blood glucose. Other than that, we may also do the HB1AC test. Then we can also check the tumor marker just to see any evidence of malignancy. For example, CEA and CA99, where CEA is for colon cancer and CA99 is for pancreatic cancer. We may also assess the tumor marker for the response, relapse, and recurrence of a confirmed GI cancer. And also, we can also do coagulation profile to see if the patients have any bleeding tendency.
Okay.
Next, we
So
can
on
also,
your
yes,
FBC, you could also what else could you look in your full blood count?
we can also look for any platelet disorders
Lagi? Why platelet disorder?
because it can cause
Describe it.
peripheral bleeding.
Okay, what else you see on your FBC?
Maybe look at the white cells differentials.
Yeah, you already written the leukocytosis. You see eosinophilia, right? Sometimes it can be because of diarrhea as well, right? So when you look at the blood parameter, you got to look as a whole.
Okay.
Okay? All right.
Mhm.
Next.
Continue. So to also do stool culture and sensitivity to determine causative mechanisms that causes infection that may predispose to diarrhea, for instance. And we can also do fecal or occult blood tests. So if the blood is not visible, we may also detect blood by using this test. We can also use this test to screen for an asymptomatic colon cancer. Mm. Moving on to imaging, we can do a plain abdominal X-ray to see the level of obstruction, and also we can see any obstruction in the small or large bowel. In this picture, we can see a small bowel obstruction, and on this picture, it's a large bowel obstruction. Next, we can also do a CT scan of abdomen and pelvis. And in this picture, I include an example of diverticular disease. So we can see positive findings like localized wall thickening, which is more than 4 millimeter, pericolic fluid stranding, or any presence of colon diverticula, which is circled here. We can also visualize the complications like abscess, obstruction, or perforation.
Okay, 1 minute.
Next, we get, all right,
Okay, wait 1 minute. All right.
okay,
So now your main topic is GI symptoms, right? They
yes,
can present as diarrhea, constipation, okay,
yeah,
or bleeding, right?
okay.
Okay, so when they come to you, you take your basic blood test, okay? So based on your um, history and also clinical findings, uh, you would run some tests, right? Okay, so you already taken a blood test. Um, so depends on your initial diagnosis, your prelim diagnosis. You would proceed with certain imaging, right? So do you do abdominal X-ray for these patients?
So for instance, if I don't think of any obstruction for my patient, then I maybe would not do abdominal X-ray for my
Okay,
patient.
okay, all right. So okay, for CT scan. So what kind of patients that you would proceed with CT scan first before other imaging? I mean before other tests. Let's do some thinking.
So maybe I would like to do initially I would like to do I would like to do colonoscopy first,
Mm-hmm.
and then if my findings is inconclusive, then maybe I would like to do proceed with CT of the abdomen and pelvis.
Okay, what would you like to see? If let's say you think like your colonoscopy is negative.
Yeah, maybe I would like to see any diverticular.
On your colonoscope, you could see
No,
diverticulum, right?
no,
Mm.
cannot.
And then the mucosa also you could assess on your colonoscopy.
Okay.
Mm-hmm.
Next.
Okay, tak apa. Continue je lah.
So next we can also do OGDS or esophagogastroduodenoscopy. So we can use this to visualize the oropharynx, esophagus, stomach, and the proximal duodenum. We can do this to look for like in the case of melena to see any perforated gastric ulcer.
Do you do upper scope? If let's say you suspect this patient has PGU, perforated gastric ulcer.
Yes, miss.
Huh? If let's say patient has, if you suspect that this patient has perforated gastric ulcer, you do a colonoscope. I mean, upper scope. Is perforated gastric ulcer acute abdomen? Just think logically. I'm asking you to think logically.
Maybe I would like to proceed with chest X-ray to look for any free air on the diaphragm.
Okay. All right. So no, you must think. All right. If let's say this patient comes to you, okay, with an acute abdomen, and then you suspect a PGU, you do not put patient on a OGDS. All right. What you have to do? What do you have to do? Stabilize the patient, optimize them, and go in for laparotomy and repair. Right? Where do you see that, they do a scope for a PGU? You've experienced, you've seen some cases like this? Hello?
Again, miss. Unstable patient,
Unstable patient?
and maybe we would like to see an GERD.
Okay, you do upper scope if let's say, okay, patient come in with upper GI bleed, all right, you want to see, or patient comes in with symptomatic, all right, GERD or whatsoever, those sort of symptoms, then yes, you do upper scope. Okay, but if let's say your indication to do a upper scope is a perforated gastric ulcer, it's wrong. Okay, you should not do a scope in a perforated or any perforated viscous per se. Okay, even if let's say there's a perforated diverticulitis, you do not do a lower scope for these patients.
All right, miss. So shall I continue?
Yes.
Okay, next, we may also do proctoscopy, so to evaluate for any lower GI pathology that causes pain like anal fissure or any bleeding like internal hemorrhoid, rectal ulceration, or rectal varices or trauma. Then we can also do sigmoidoscopy, where it can be divided into rigid and flexible sigmoidoscopy. So, for instance, we can detect hepatitis in the case of IBD to look for hyperuremic mucosa and also any bleeding and also purulent exudate. So, rigid sigmoidoscopy, we can also do it to identify any bleeding hemorrhoids or any rectal cancer. We can do this in the setting. Then lastly, we can also do colonoscopy. It has a diagnostic as well as a therapeutic procedure just to perform to evaluate the large intestine like the colon, rectum, and anus, as well as the distal portion of the small intestine, which is the terminal ileum. So we can do this in non or occult gastrointestinal bleeding or any stool positive for occult blood, any unexplained changes in bowel habits, in iron deficiency anemia, or any elderly patients with weight loss, or any suspected inflammatory or infectious colitis. All right, moving on to the management by Mazatul Haikal.
So, hello, my name is Mazia Tuhaika, and I will be presenting the management of constipation, diarrhea, and rectal bleeding. So, for constipation, I would like to categorize it into two, non-pharmacological and pharmacological. So non-pharmacological basically change, improve lifestyle and diet, and pharmacological basically laxative and prokinetic agents. So for non-pharmacological, it's basically to correct the dietary deficiency of the patient by increasing the intake of fiber and fluids, example fruits, vegetables, and reducing the intake of constipating agents such as alcohol, coffee, tea, and to improve the lifestyle by doing exercise, which stimulates the bowel motility. Next, pharmacological by using laxatives. So there are many types of laxatives. One of them is bulk laxative, which swells and distends the colon and increases the peristaltic motility. And it also it has fiber that acts by absorbing water and promotes bacterial growth. And basically, we use bulk laxative for acute chronic constipation (IBS) and diverticulosis. Next is a surfactant or stool softener, which it lowers the surface tension of the stool and allows additional water and fat to enter the stool. So the stool will be easier to move the GI tract. So usually it's used for softening of the fecal impaction that facilitates the bowel movement in anorectal conditions. Moving on, lubricant laxatives, which, as the name is, it coats the stool with slippery lipids and reduces the absorption of water. So the stool can slide through the colon easily. So this is also used for acute or subacute management of constipation. It shouldn't be used more than 7 days and not in elderly or children less than 6 years old or bedridden because they will have a depletion of the fat soluble vitamins. Moving on, osmotic laxatives, which increases the small and large bowel fluid volume by osmosis. So it increases the peristaltic motility and expulsion, and this is for chronic constipation, diagnostic and surgical preps. Next, last but not least, stimulant laxatives, which increases the intestinal motility and activity. So it's basically used for acute constipation, diagnostic, and surgical preps. Next, so these are the types of laxatives, and it's easier to understand. Moving on, next is prokinetic agents. So, such as cholinergic agonists, which increases the release of stimulating neurotransmitters. So, it basically acts on the muscarinic receptor and increases the vascular tone and tension of the contraction and peristaltic activity of the intestine. And other than that, opioid antagonists, which inhibits the action of the inhibitory neurotransmitter. So it acts on the opioid receptor and increases the smooth muscle tone, which accelerates gastric emptying, reduces transit time of the large bowel. So last is macrolide antibiotics, which acts on the gastric hormone receptor, which is motilin receptor agonist, and increases the motility of the stomach and small bowels. So it increases the gallbladder contraction, hence, um, it fastens the gastric empty. So next is diarrhea. So in management of diarrhea, first we have to manage the cause of diarrhea. It's either dietary or drugs, so we have to avoid and change the lifestyle. Tumors, so if it's tumor, we have to remove the tumor, and if it's from infectious cause, we have to eradicate it. And Basically, the management of diarrhea, we have to manage the dehydration, electrolyte imbalance due to the diarrhea. So, um, the management of diarrhea, which causes dehydration and electrolyte imbalance, it can be mild dehydration, which the patient is quite stable. So we can just encourage the patient to drink plenty of water. Or it could be moderate or severe dehydration with loss of electrolyte imbalance, which we can give oral rehydration solution. Or the unstable patients with severe dehydration, they are in need of IV solution of normal saline and antidiarrheal agents. So oral rehydration salts, they replenish the electrolyte imbalance and water solution. So basically it has glucose, sodium, chloride, potassium, chloride, and trisodium citrates, which stimulates the body to absorb water. Next. So these are the anti-diarrheal agents. So there is anti-motility agents, which is opioids and anticholinergic. Basically, opioids are to slow down the intestinal contraction, increase the time for water absorption, and anticholinergic is to relieve the spasm due to peptic ulcer disease, diverticulitis, IBS, because it blocks the action of acetylcholine on smooth muscles of the GI tract. And next is mucosal protectant and adsorbent, which we all know, activated charcoal. So it basically coats the wall of the GIT and binds to the causative bacteria or toxin, and it eliminates the toxin and all through the stool. So it also coats and protects the intestinal mucosa, which decreases the fluid secretion in the bowel. And last but not least, perectal bleeding. So, um, management of perectal bleeding is actually based on the severity. It's either first you have to do emergency management, and then there's endoscopic hemostasis, angiographic embolization, and surgical intervention. So patients with perectal bleeding, uh, which are unstable, they should be resuscitated. Basically to basically hemostatic resuscitation, because some patients with perectal bleeding come tachycardic and hypotensive. So in emergency management, so we have to do an A to E standard approach. We have to give IV fluids and vasopressors in more severe cases. Next is endoscopic hemostasis, which if the patient has signs of active bleeding, so it's better to give injection therapy, which is normal saline, diluted epinephrine, or catheterization, which is heater probes, and mechanical therapy, band ligation. Next is angiographic embolization, which is patients with ongoing GI bleeding. So it's an alternative for colonoscopy in patients with acute lower GI bleeding who cannot tolerate bowel prep. So, but this you have to consider in patients with rebleeding or ongoing bleeding despite endoscopic hemostasis. Yeah. And last but not least, surgical intervention. If all therapeutic options fail, so we have to consider hemodynamically unstable patients with ongoing bleeding to do surgery and angiographic embolization. So they can also be considered to do exploratory laparotomy and surgical hemostasis, which they might have to do a segmental bowel resection. That is all from us. Thank you.
Okay, good. So I think essentially your topic, you should know what are the causes mainly, right? Okay, what are the cause of diarrhea, constipation, and PR bleed? Okay, from there you because I think the topic is very wide. Okay, all right. So you have to know how to clock the patient in terms like for you to um, establish a diagnosis. Okay, at the end of your clocking and examination. Okay, so if let's say this is a very general topic, so I suppose you guys need to know mainly what are the causes and how you would investigate them. Okay, first at this point. Okay, and then you would know how to treat them depending on your uh, diagnosis. Okay, right? Because the causes are very wide. So do you all have any questions?
No, doctor.
No questions on this.
No.
Okay, right. The others? Tak ada. Okay, then I think since you guys got no question, then we call it a day lah.
Okay, doctor.
Okay.
Thank you.
Thank you.
Mm-mm.